you over now.
Okay, sorry, I'm listening now.
Just identify the nature. Do you want it? Yeah. Yeah. So then, what I told, so in the eye, what specific muscle, what do we name? I wrote mine actually on the board.
Yeah.
So I did that. What would be the name of the
Okay, so where it says muscle, we want the muscle, not the...
Right.
Вчера так завидно было.
So this one you want a muscle tissue?
Yeah.
Okay, all right.
Maybe like years.
All right, so lateral spinal thalamic tract and the anterior one as well carry pain, touch, and temperature. So on page,
Wait, we got a new packet.
just before the motor pathway on page 115 is a discussion of pain transmission that we kind of skipped over on Friday. So page 115 of your lecture notes, and I just want to highlight what's going on here. So if we have some kind of sharp object poking into the skin, all right, we have neurons that are receptors. Now, we haven't really talked about, this comes into our neurophysiology, but a cell that functions as a receptor. So something like the pressure receptors in the blood vessels for, I talked about glossopharyngeal and vagus nerve. We have pressure receptors in the internal carotid artery or in the aortic sinus that are sensitive to stretch, all right? And we have pain receptors that are sensitive to chemicals for pain. So these neurons do not have long processes. They are only capable of generating what we call graded potentials. So they don't create an action potential. So the signal, the current that they make is very temporary, and it's not capable of going a long distance. It peters out like a wave. If you throw a rock into a pond, the ripple is not going to stay the same strength. So receptors generate a weak current that dissipates, but if the current is strong enough, it will cause that receptor to release various chemicals. Okay? These chemicals irritate the ending of a pseudomunipolar neuron, and it will actually cause it to send a signal. So normally we don't trigger, we don't activate signals at this end of a neuron, but and I've listed these substances, bradykinin, ATP, can be triggered to cause a signal to go up a pain neuron. And so this neuron would have its cell body in the dorsal root ganglion. It's our first order neuron, and it's going to end in the posterior gray horn with the second order neuron, which is going to cross over. Okay, and a very the neurotransmitter between the first and the second order neuron. The two common ones that are going to be released here are glutamate and substance P. Glutamate's a pretty common central nervous neuron, but substance P I want you to recognize as a major neurotransmitter in our pain pathway. So between the first and second order neurons, we have substance P. And then we continue to see glutamate between second and third and so on. Now, most of you have probably heard of endorphins. We're going to talk about neuromodulators in our next unit. And endorphins are naturally producing pain-blocking or euphoric-inducing substance that your body makes. Now, let me see, I don't know if any of you have tattoos. In my semester class last semester, I had one tattoo artist and another woman whose husband was a tattoo artist. And so my own son got a tattoo after his grandfather died that spring. So we had multiple conversations about tattoos. And you probably, if you don't get tattoos yourself, I've heard, and they confirmed, that once an individual gets a tattoo, they're more likely to get another one, and then they're more likely to get more and more and more. And it appears to be more than just a collection of art, but that they almost become addicted to the pain that's caused by the tattoo. It causes a release of these endorphins. You've heard of runners, all right? My daughter's in her first cross-country race this afternoon. She's been running just to keep up with her conditioning since the football class closed. And the school started a cross-country team, but they meet on Friday afternoons, and she always has her horseback riding lessons. But they invited anybody that wanted to run to go to the meet today. So she's all excited about it. We do the Run to Feed the Hungry, and she always has done the 3K. This is 5 miles, no, 3 miles. For this one, it's either a 3K or 3 miles. So it's not a very long cross-country race. And so she said, the only wrong thing about this, Mom, she says, is my running shirt is see-through. I'm going, okay. Just run really fast. But people get addicted to running. They don't feel good if they don't do, they miss a day or two in their daily run. So a lot of this has been triggered, some of the studies of pain that releases these endorphins and enkephalins, and these are other internal forms of neurotransmitters that elevate your mood.
You also start getting runner high. It's I don't know. They don't have anything.
I've never run enough long enough.
Yeah, right.
It's actually you can run where you think I've got that high where you're looking down on yourself running.
Running?
I've done it. Look down myself running, going, that's pretty cool. And then I'm looking around. I'm like, wait, after 4 miles, that's me still running. Yeah, there's a high.
That's like euphoric feeling that you're talking about, though.
Yeah.
I would say the closest I've come to that, and I didn't interpret it as that, but I always felt, the most I've ever run was 6 miles, and I did it at night. And it wasn't an otherworldly experience, and I attribute it more to being black and at night, and I wasn't focused on, I have to get to the next intersection, I have to make it to the next stoplight. I was just release of all of that timing and measuring and just running for the sake of running, and I interpret it more as being surrounded by dark and not not paying attention to the sensory stimuli, rather than it wasn't exactly a euphoric thing. I interpret it as just, I can run and not worry about how far I have to run kind of thing. So these chemicals are listed under the blockage of pain transmissions. So endorphin is a known neurotransmitter that's a mood elevator. Forms of serotonin are used in antidepressive type medications. But endorphins and enkephalins are more seen directly with inhibiting pain or actually providing pleasure. I just want you to recognize substance P is a neurotransmitter, endorphins and enkephalins as blockers, either mood elevators or blocking the substance P from being allowed to trigger an action potential. And I'm not going into that anymore this time because that's neurophysiology. Neurophysiology we start on Thursday. Okay?
So glutamate is the blocker?
Pardon? Substance P is part of the neurotransmitter for the pain pathway, and then enkephalins and endorphins can block that pathway.
Okay.
Some people are more tolerant to pain versus the pain receptor is stronger, so to say.
That, or they don't have the number of receptors. So I always have thought that my youngest son, my mother dropped a fork on his head when he was about 2 months old. And he didn't flinch, he didn't cry. So from that time on, I haven't actually tested it out to see whether I can poke him harder than his twin sister. But yeah, I think it's either in that or it's in the processing, mental processing of it. Because there is when I was, my husband and I were dating, and I'd come out to see him for Thanksgiving, and we were doing the dishes or something, and I started getting a menstrual cramp. And my period was late, and so I interpreted it as every once, as just the beginning of my period. Which I didn't get a lot of cramping, but I just thought it was that. Well, it got worse and worse and worse, and I went to lay down on the floor in his living room, and I was kind of curled up in the fetal position. And it was a really bad, strong, visceral kind of pain. And he came over and just laid his hand on my shoulder, and I said, please don't touch me. We ended up going to the emergency room, and it was a urinary tract infection along with ovulation, which I normally hadn't noticed ovulation. Some people feel it every month. It's called Mittelschmerz. And I'd never felt it. And that combined, but it was made more painful with the urinary tract infection. And so that really bothered him, the fact that I didn't want him to touch me. So on the way home, he said, I really didn't like you're telling me not to touch you when you were on the floor. He said, how's that going to work when we have babies and you're in labor and you kick me out of the labor room? And I was like, and I tried to explain to him that it took all of my mental effort to deal with the pain. And as soon as he touched me, part of my brain had to stop dealing with the pain and acknowledge the sensation of him touching my shoulder, which made the pain more intense. And I couldn't deal with both sensations coming into my brain. And he didn't accept it. And I just said, wait till you have a kidney stone. And they don't know what I'm talking about. I was just wishing a kidney stone on him. But that's the best I could say, was it takes all of my mental power to just breathe through and, and deal with that. So I don't know if different people in the thalamus, or if it's a combination of the pain all along the way. Because obviously, we can do things to ignore pain. You've heard of people who break a bone in the middle of a soccer game or a football game, and in their hand or in their fibula, and they don't even notice it until the game is over, okay, because of all the other input coming into their cortex, that they just only process certain components of that. All right, so I wanted to just mention those components there, and then we moved on to so let's just review a little bit of what we covered in our motor pathway. So remember I said on the exam on Thursday, there is a page in which I have chosen 3 of either sensory, a combination of sensory and motor pathways, and shrunk them down so they're only about 1.5 to 2 inches long. And then asked a bunch of questions about them, all right? So if I have something like this up on the exam, I might say, identify this pathway. So the multiple choice question answers would be all of our pathways: cortical bulbar, cortical spinal, tectospinal, vestibulospinal, spinal cerebellar. I can go A, B, C, multiple answers. Is it a motor or sensory pathway? So how would you identify whether this is a motor or a sensory pathway?
Because of synapse in the thalamus.
Okay, so it's not in the thalamus. If it was cortical spinal, we could see that it was passing through the ventral root. That would tell us it was motor. But we've got a cell body up here instead of the axon terminals. Okay, so there's several different things you can look at to identify whether it's an ascending or a descending pathway. Cortical bulbar, what's the similarity, what's the difference between a cortical bulbar pathway and a cortical spinal pathway?
The cortical bulbar doesn't go through the spine.
Right, so cortical bulbar is going to be, and in fact I have it showing going to just one side. To make this complete, this pathway actually crosses over. It's a bilateral pathway. So we would have a neuron, we would have this neuron.
Professor, what page in the notes is this going on?
120.
Thank you. It's on the same, it's cortical spinal.
She doesn't have bulbar, she wants to draw it onto that one.
So what is this? So basically,
And then it would also do this. So I'd say bolus is a conscious motor pathway. And it is, I only showed you one, but it's bilateral. So this is going to be coming out both sides. cranial nerves do. All right? So trigeminal has motor for chewing muscles to the tongue. If we were to draw a cortical bulbar pathway for the hypoglossal nerve, it's going to come all the way down to the medulla, because that's where our hypoglossal nerve is. So any of our cranial nerves that have motor components to the voluntary motor would be forming in the cortical bulbar pathway. All right? So we would still have an upper motor neuron and we'd still have a lower motor neuron.
So if it starts from the brain or it has a thalamus, it starts from the thalamus motor?
If it has its cell body in the cerebral cortex, it's going to be motor. Okay? If it has an upper motor neuron. Now what we didn't finish on, so this is cortical spinal pathway. All right, so in addition to having you identify the pathway on those multiple choice questions, I would have you identify one of the or more of the neurons. So in a motor pathway, we have the upper motor neuron, and then we have the lower motor neuron. All right. First and second order neurons are for sensory pathways. I might ask you to identify this structure right here, the peduncle. If it was a sensory pathway, I might have you identify the posterior column or the nucleus gracilis and cuneatus. Okay? So there's a series of questions asking you to identify the pathway, identify the neuron, is it sensory or motor, identify one or more components of that pathway like the thalamus or the cerebral peduncle or the nucleus gracilis, cuneatus, and so on. Okay? Now, what was the significance of this? We talked about, this is still a cortical spinal pathway. This is why the basal pons is so large. These are called pontine nuclei. And notice in this previous one, that was a cortical bulbar, the lower motor neuron left the brainstem as a cranial nerve. And the slide that we went to, that doesn't leave the cranial nerve. Instead, it goes to the cerebellum. So this is a middle cerebellar peduncle. Remember the function of the cerebellum was to bring in, it's a black box, and the sensory pathway, we go back to our sensory pathway. Remember the spinal cerebellar peduncle pathway? So spinal cerebellar, our inferior cerebellar peduncle, is formed of sensory information, subconscious sensory information coming from my muscle. So I can tell you right now that my hip joint is extended and my knee is extended, and now I can tell you my knee is flexed. All right, that's going to be the proprioception. That's going to be the posterior column pathway. This pathway is unconscious, or subconscious, I should say. So this is just, I'll get back, I'm just looking at cerebellar peduncle. So this is subconscious processing of joint position. All right, that's what's going through the inferior cerebellar peduncle. Remember, we have descending information going to the cerebellum, telling my cerebellum what my muscles are doing or about to do. And that's what I showed you in that last slide right here, forming the middle cerebellar peduncle. Okay, so this is all under lateral cortical spinal tract. So in our cortical spinal tract, our upper motor neuron passes through the cerebral peduncle, not through, that should be going on through here, through the pons, crosses over in the medulla, and goes down the side of the spinal cord to synapse with the lower motor neuron. Okay? That's what forms our cerebral peduncles. That's what forms our pyramids, are those descending upper motor neurons. What makes the pons, the basal pons, so large is that some of the neurons in our cerebral peduncle stop in the cerebellum and synapse with nuclei cell bodies there that go into the cerebellum. That's what makes that huge middle cerebellar peduncle. Those are the parts of those motor fibers. Those are lower motor neurons going into the cerebellum to let the cerebellum know what I'm telling my muscles to do. Okay, so we see that as a subset again of the cortical spinal tract. So cortical bulbar is forming cranial nerves. Our normal cortical spinal tract is going all the way down to the spinal cord. But then some of those neurons will stop in the pons and go to the cerebellum. And that's when we have the pontine nuclei.
But that one is the middle
That would be the middle
cerebellar.
cerebellar.
Okay.
Okay, made up of those neurons. It's not going to muscle, so it's not going to make the cerebellum do anything. It's just telling the cerebellum what I'm telling my other muscles to do.
Are these all in PowerPoint?
Uh-huh. Yeah. All right. Now, before, I kind of did this as a review this morning, but since we're going through these slides, I'll do it at this point. What if I were to have, let's see if I moved it. All right, so what if I were to place a lesion, I know where it was.
Those lesions. Yeah, where that sweatshirt went.
What if I were to place a lesion in my upper motor neuron, here where it's passing through the cerebral peduncle?
It's white, makes me feel clean.
That black bar
Any other color.
is a lesion or damage to my cerebral peduncle. I've cut all those upper motor neurons in my right cerebral peduncle. Will I lose motor or sensory function? Motor, okay? What do we call it when we lose motor function? Paralysis. So this would be cutting the upper motor neuron. This would be called paralysis. Is it going to result in contralateral or ipsilateral paralysis? Contralateral. So if it's upper motor neuron before it crosses, before decussation, it's going to result in contralateral
I already have it.
paralysis. If it's after decussation, and that's our fancy word for the crossing over in the medullary pyramids, it's ipsilateral. Now, will my lower motor neurons still be intact? Will my lower motor neurons still be functional?
Well,
Yeah.
it's still there, but it's not functional, right?
What about a reflex?
Okay.
Will the reflex still work? Yes. So remember, we call this type of paralysis then spastic. Because I couldn't voluntarily move that muscle, but it would respond to a sensory stimuli. Okay? So that would be spastic paralysis. Now what about my lower motor neurons? If I cut my lower motor neuron, either out there, which would involve losing sensory function, or we cut the ventral root. So that's the lower motor neuron. Does the lower motor neuron cross? No. So I don't have to worry about before or after decussation. It's always going to be ipsilateral paralysis. I'm always going to have paralysis from those muscle cells innervated by those motor neurons. Okay. What's our term? Our upper motor neurons intact. We can send all the stimuli we want, but it does no way of getting to the muscle, and then we can stimulate all we want, and there's still no return. So here where I've cut the ventral root, my dorsal root is still intact, and I can send sensory input there, but even if it connects, there's no activation of the lower motor neuron. And so this is flaccid paralysis. Okay? All right, so moving back then to our motor. So we had talked about cortical spinal already on Friday. and we had done tectospinal. Okay, so let's go back to tectospinal then. Remember what the tectum was? Tectum was the roof of the, it's kind of another name for the corpora quadrigemina, except it includes some other parts. So it's the roof of the cerebral aqueduct, which is formed by the corpora quadrigemina. Okay? So when we talk about the tectospinal tract, we're talking about upper motor neurons that are in the superior colliculus or in the inferior colliculus. So superior colliculus is for visual, or auditory reflexes.
Visual.
Visual, okay? So optic nerves can come directly to the superior colliculus, or from the thalamus can come to the superior colliculus, and synapse with that essentially upper motor neuron. So would this be a conscious movement of my eyeball or a subconscious?
Subconscious.
Subconscious, because it's not involving the cortex, okay? So that is then, if it's going to move, say, my lateral rectus to look out, it's going to go to which neuron? What nuclei of what cranial nerve?
It's at the occipital.
Lateral rectus. What nerve? AB dots the eye.
Oh, the abductors
Yeah, the abducens.
or abducens.
Okay, so it's going to go to cranial nerve 6. But as one eye is abducted, the other eye is medial, and that's ocular motor. All right, so I'm going to have upper motor neurons going both to ocular motor and coming down to cranial nerve 6. And then I would have my lower motor neuron, which would be the cell body of that cranial nerve. All right? So the lower motor neuron would be the nerve in either cranial nerve 3 or 4 or 6, whichever one, mostly 3 and 6. So you know that this is a reflex movement. It's a subconscious movement because no cortex is involved. So without the cortex, how do I know that this is a motor pathway and not a sensory pathway?
The cell bodies are in the central nerves?
Okay, so our pathway, we're not involving any, we don't have any pseudo-unipolar neuron or bipolar neuron, okay? Cell bodies are the beginning of our pathway. If this was a sensory pathway, we would have, the pathway would be ending with the axon terminals, not starting with the cell body. All right, so either superior or inferior colliculus. If it's inferior, it's auditory, and I don't move my eyeballs for reflex to sound. I might cognitively, consciously, move my eyeball to see where a sound is coming from, but the reflex movement is going to be turning my head. All right, so then I have to send, if it's turning my head, I have to send it down to the, at least the cervical spinal cord. So even though this goes down to the spinal cord, how do you know that it is a reflexive movement? Again, it's starting in the midbrain, not in the cortex. So you would name it tectospinal. This should actually be up a little higher. I don't want you confusing it with the rubrospinal pathway, because that's kind of in between. So let me just move this up here a little bit. Group together, but anyway, if you like that. Okay, so that's tectospinal, and this is where we stopped, was the rubrospinal. So I said you were going to learn 2 new things on Friday. Anybody remember what the first new thing was you learned? That's this one. The ribs. Medial lemniscus. Okay. So rubrospinal refers to the red nucleus, which is part of the midbrain, and this is the motor kind of component of the spinal cerebellar tract. So remember, spinal cerebellar was subconscious balance control. This is subconscious motor pathway of that, but primarily for posture, a little bit for our extensor muscles, but primarily, our flexor muscles, but primarily for posture. And so it starts in the midbrain, crosses over, and goes out the spinal cord. So notice it's lower. It would, for the tectospinal, it's going to have to be up in the colliculi. All right, rubrospinal, the red nucleus is, if I were to draw a larger midbrain here. This would be our substantia nigra, and red nucleus is right here. Okay. So again, a subconscious motor response to changes in posture. So I don't have to think about physically holding up my back and sitting up straight and standing up. That I would, if I don't think about it the whole time, I would just collapse. So this is part of that not having to think about, unless your mom says stand up straight kind of thing. Or the drill sergeant or whatever. All right, then we have just one. This one is also for balance, a little more so balance than posture. This is the vestibulospinal tract. Again, by its name, you can tell that it's a motor. It's coming from the nucleus, coming input from the cerebellum, as well as input from the nucleus for the cranial nerve 8, which is the inner ear for balance. Okay? So I've just drawn the cerebellum here, but it also is going to include between the pons and medulla, the vestibular portion of sensory input from cranial nerve 8. So both of those, I think, yeah, here we go. Here's cranial nerve 8 component. And that then, notice that this is an uncrossed pathway. So this is on the same side. So it does both, but ipsilateral predominates, so I've just drawn ipsilateral. So the inferior cerebellar peduncle sends information to the cerebellum for what our joints are doing. And the vestibulospinal tract, along with the tectospinal tract, is the motor input going out to interact with that sensory input, so we don't have to think about it consciously. I have to stand, I have to sit upright, when I'm walking, I have to balance what both my lower limbs are doing. So this would be the motor output along with tectonospinal for your back to the spinocerebellar input coming in through the inferior cerebellar peduncle. That's the end of lecture. No more new material. Now, I told you that your extra credit would be one of these pathways. All right, so 3 of these pathways, sensory and motor, I'll miniaturize, and it'll have the lines drawn on there, but not the labels. And so I would ask you to name the pathway. Is it sensory or motor? Identify the gyrus, or identify the nucleus. Also identify the neuron. Is it upper, lower? Is it primary? Is it first, second, third order neuron? Okay? Then I have the same structures from cortex to spinal cord, just like you see if I can borrow this sheet. So just like this, but a little bit, so I didn't have to use a whole extra page. I put it sideways, so you're going to draw it, turn it like that. All right? It'll look just like this. And then at the top, I'll say, for extra credit, diagram the pathway that carries pain, touch, and temperature. So first of all, I have to figure out what that pathway is. And it's the lateral spinal thalamic pathway, okay? Or I might say diagram the pathway that is voluntary motor neurons to the upper limb. That would be your cortical spinal pathway. Or I might say diagram the pathway that carries conscious proprioception. That would be the posterior column pathway, okay? Then, so diagramming it, so you would get points for putting the neurons in the right place. So if you don't have the, you have the third order neuron, let's go to the, posterior column pathway here. All right, so let's say that instead of having the third order neuron start in the thalamus, you had it start down in the midbrain, okay? Or let's say you took your first order neuron and you had it stop in the posterior gray horn, and your second order neuron went up the posterior column pathway to the nucleus cuneatus and gracilis. Well, your second order neuron wouldn't get any credit at all, because you didn't have it cross over. And its cell body was in the wrong place, but I would give you partial credit for your first order neuron, because at least you had the cell body in the dorsal root ganglion coming into the dorsal root. All right? So there would be points possible, and these are about 8 points for the diagram. There would be points possible for putting the neurons in the right place. Points for naming them, so calling it the first order neuron instead of the lower motor neuron. All right? And then I would say identify all the nuclei, ganglia, and gyri involved. So for the posterior column pathway, you're going to identify dorsal root ganglion, nucleus cuneatus gracilis, and I don't ask you to distinguish between them, medial lemniscus, thalamus, and postcentral gyrus. Okay? If it was a motor pathway, then, and you were drawing the cortical spinal pathway, then you would be identifying cerebral peduncle, medullary pyramids, anterior gray horn, ventral root, and precentral gyrus. Okay. So as you practice diagramming these, let's go look at the cortical spinal pathway here. So be able to identify any of these structures that I have on there. The terms for them, if you can't remember all those terms, will be on that page where I have multiple choice on the pathways. Okay? So all the neurons are there, all the structures are there, all the pathways are there. So if you can't remember a word, just turn the page and all the words that you would possibly use would be on that list. Okay? So it's kind of what the homework for, since we're finishing the pathways today, the homework for Thursday is just answering these types of questions. So your exam on Thursday is 70 multiple choice questions involving 70 multiple choice questions involving the pathways as well, but also, remember I said understanding the embryonic vesicle, so I'll have a diagram of the telencephalon and diencephalon labeled, and then a matching. The thalamus is associated with which of these embryonic vesicles? Diencephalon. The corpora quadrigemina would be associated with which of these? Mesencephalon. So corpora quadrigemina is midbrain, midbrain is mesencephalon. The postcentral gyrus.
That's
Telencephalon. Okay, so there'd be questions like that, not a lot, 3 or 4. Questions about the ventricles, matching. So the lateral ventricle, we had anterior horn, an inferior horn, and posterior horn. Then third ventricle, cerebral aqueduct, and fourth ventricle. All right. So if I said cerebellum, what ventricle would you associate with the cerebellum? Fourth ventricle. Forms the roof of the fourth ventricle. Tail of the caudate nucleus. Tail.
That's the anterior nucleus.
So that's head. It is the amygdala, but what ventricle structure would you associate? So remember the, not posterior, inferior. So our lateral ventricle is shaped like this. And the head of the caudate fits in here. And the tail fits there. So the tail of the caudate is the roof of the inferior horn. Okay. Head of the caudate bulges into the anterior horn. Occipital lobe would be associated with posterior horn. Okay. Pineal gland. What ventricle would we associate the pineal gland with? Third ventricle, because it grows out of the roof of the third ventricle. Okay. There will be questions where I ask, is it motor, sensory, or both? So ventral root of the spinal column. Motor. Okay. If I said ventral ramus, it would be both. Remember the spinal cord of ventral ramus is both sensory and motor? Dorsal ramus is both sensory and motor. Ventral root, dorsal root would be only motor, only sensory. What about if I said medullary pyramid? Motor. Okay. What if I said lateral white column?
Lateral white column, that's motor.
Both. Because it has the lateral spinal thalamic and it has the lateral cortical spinal. So the only white column that has only one is the posterior white, which is sensory. The anterior and lateral are both. Okay? There will also be questions about the cranial nerves, obviously.
I like that one.
So remember I said I would have a table with boxes and the different cranial nerves. And so if I said, well, give me some examples of a cranial nerve, which is any cranial nerve, which is motor.
Facial.
Facial.
Trigeminal.
It's a whole bunch. Trigeminal,
Hypoglossal.
abducens, ocular motor, accessory. You could fill a whole thing. What about special senses?
Olfactory.
Olfactory,
1, 2,
cranial 1, optic 2, 7 is taste, and 9 and 10 are taste. 8 is balance and hearing. Okay, so smell, vision, balance and hearing, and taste, special senses. So even if I had only 3, we've got 6 or so nerves for the 7 senses. Movement of the eyeball. Not 7. 3, ocular motor. 6 is abducens, and 4 is trochlear. Okay, so again, I would have the cranial nerve number and the name, and then you would just put down 3 for ocular motor. Sensory to the eye, anything that innervates the eye, 5, 1. So if you couldn't remember if it was 1, 2, or 3, you just put 5, you get half a point. Okay, but 5, 1 is going to be sensory from the eye. If I said innervation of the tongue,
Innervation, that's the
hypoglossal for motor. Facial is for taste, sweet, sour, and salty. Glossopharyngeal is taste for bitter.
The facial? Or the
Facial is for taste,
vagus nerve?
not for not vagus, not for taste. That's like the palate and the sides of the mouth. No, that's eyeball movement. One more nerve. 5-3, pain, touch, and temperature. Okay? 5 is 3 branches. The third branch is pain, touch, and temperature from the mouth and the chin and so on. If all you could remember was 5 instead of 5-3. But I have 5-1, 5-2, 5-3 listed to remind you that they have different components. We already did taste, so 9 and 10 and 7 for taste. Okay, so just different combinations like that. It may just be 1. Identify the cranial nerve that causes constriction of the pupil.
2.
No, it's not 2. That's just too easy.
3.
Ocular motor.
3. Okay. So when I talk about the pupillary reflex, though, identify the 2 cranial nerves involved in the pupillary reflex. So what's the pupillary reflex? It's part of your cranial nerve. So shining a light in someone's eye, the result is the pupil constricts. Okay? So what would be the 2 cranial nerves involved? Ocular motor is going to cause that's corneal reflex. Ocular motor is going to cause the pupil to constrict, but how are we going to get that sensory impulse to the ocular motor nerve? Optic. So the light is what results in the pupil constricting. So the light is carried by that innervation, is activating the optic. So you put cranial nerve 2. The constriction is the pupil constricting. That's cranial nerve 3. Okay. What's our blink reflex or the corneal reflex? That's where we get sensory.
It's 2.
No. Sensory to the eye.
When blink
It's 5.
Well, if I do this, I'll blink and I don't even.
Yeah, but if you just, but the procedure is touching the test on the cranial nerve pathway test was touching the cornea. So even if, yeah, my daughter would blink just if you went like that to her. But touching the cornea would be 5-1.
It's gonna go bleed.
You wear contacts, I bet.
Yeah.
So that would be 5-1, touching the surface of the cornea and then closing the eyelid. Of course, when we blink, we also open it, but in the closing of the eyelid is what we refer to for the blink reflex or the corneal reflex. So what nerve does muscles of facial expression?
Facial
Facial
nerve.
nerves. Okay. So what would open the eye? Yes, that's ocular motor. Okay. So that would be another portion, and then there's the short answers. I cut down from 15 to just 5.
Yay.
And I actually put all the answers up on the page too.
Yay. For 20 answers and 5 questions.
So, in other words, identify the blood vessels that pass through the foramen magnum.